doctors, it is always a pleasure to be in the presence of such competent and esteemed doctors. Today we have Dr. Kebayoni Gary, our vascular surgeon, Dr. Gure, our cardiologist, Dr. Francis, our radiologist, and Dr. Faisal, our pulmonologist. The case presented before you is that of Mrs. John. She's a 72-year-old African-American woman who was admitted with CC, increasing leg edema, weakness, and coughing without bringing up any phlegm. Now, in the emergency room, she was noted to be presenting with supraventricular tachycardia, and despite 3 doses of adenosine, she did not respond. Currently, she's in the intensive unit and on cardicem drip. Now, Mrs. John was not able to give any details of her present or past medical history, except for the fact that she has been a smoker for the past 30 years. What we did determine from our research, though, was that she had hypercholesterolemia, hypertension, and recurrent SVTs. We also found that she was non-compliant with her medications and did not even know their names.
Dr. Gauri,
Yes,
how are
doctor?
Miss John's better since this morning?
This morning, when we checked on her, her heart rate varied from 130 to 90, her blood pressure was 128 and 71, and RR was 17. We also found that she was JVD positive and exhibited scattered wheezing. We also found that in her clear S1 and S2 sounds were noted with no murmurs or gallops but an irregular rhythm. In the abdominal region, we found a colostomy bag with dark formed stool but no evidence of melena. And in the extremities, her LLE was warm while her RLE was swollen but not red. She also displayed erythematous skin with +2 pitting edema. Now, I'll hand Dr. Gray will now continue.
Yes, in the emergency room, we find it suitable to take an ECG and run some blood tests. The blood tests were to determine the D-dimer levels, which would help us to identify if the patient had VDT. So all other blood tests were done, like creatinine, burn, electrolyte, and as well as a full blood count. The results show that the burn and the creatinine were at baseline, and the 2 cardiac enzymes showed negative for myocardial ischemia, and the positive D-dimer obtained indicated whether she had either congestive heart failure or PE. And due to the severity of her symptoms, we treated her for CHF exacerbation and pneumonia. And also LE duplex showed an LLE DVT, so we started her on digitoxin. One thing we noted was that she complained of shortness of breath.
I beg your pardon, but why was she started on digitoxin so quickly?
Well, we started on digitoxin in order to relieve her symptoms as we continued with more tests in order to come up with a more concrete diagnosis. However, the treatment did not relieve her dyspnea, so we stopped it immediately. So we endeavored into doing a more careful examination of the ECG. That's when we realized that we had S waves in the lead 1. We had large Q waves in lead 3, and we also found that there were inverted T waves in lead 3. So we concluded that the patient had PE.
Okay, so Dr. Francis, our radiologist, will now further this diagnosis. Dr. Francis?
Yes. Okay, firstly we did a CT of the chest, and this showed extensive PE. So we went on further to do a pulmonary angiograph, and this is the gold standard for differential diagnosis of PE. So here are the results, and as you can see, there is major contrast. Okay, we have the white areas, and these are the normal areas, but the darker areas, these are the areas where we have pulmonary vessel defects. Okay, and in these areas, as you can see these dark areas here, these pulmonary defects may have an embolus, amniotic fluid, or fat. Okay, so we concluded that Mrs. John definitely has some embolus present.
Okay, so based on what Dr. Francis just said and the results from the ECG and the blood test, we can conclude that Mrs. John had pulmonary embolism.
However, did you know that 21% of pulmonary embolism is asymptomatic, or there may be signs of deep vein thrombosis? In rare cases, such as these, thrombosis may be massive, but still, venous blood flow isn't completely blocked, and the onset of ischemia would be delayed, or it may even be absent.
Yes, but Dr. Faisal, the incidence of pulmonary embolism rises sharply after the age of 60. The fact that Mrs. John is a 72-year-old African-American female, her possession of hemoglobin S predisposed her to the condition, not to mention the heart disease and her cigarette smoking. She has been a smoker for over 30 years now, and her cardiac problems make it worse. She certainly presents with multiple risk factors like endothelial injury and supraventricular tachycardia. But there's also a twofold increase due to the fact that she has had children and may have used hormone therapy in the past.
I'm sorry, maybe you're not understanding me, but 25% of the patients with PE, the initial manifestation is usually death. Rather, 10% of them, within 1 hour of the onset of the symptoms, we tend to lose them. We must act quickly if she does have PE, and death would occur with 85% blockage of the pulmonary artery.
Actually, pulmonary embolism is the occlusion of one or more pulmonary arteries by thrombin that originates elsewhere, typically in the large veins of the lower extremity or pelvis. For this condition, the risk factors are those factors that impair venous return, and nearly all PEs arise from veins in the lower extremity or pelvis, that is, deep vein thrombosis. And thrombin in either the lower extremity or pelvis may be occurred, and the risk of embolization is higher with thrombin in the lower extremity or pelvis.
Dr. Gary, did you say it's only restricted to the lower extremities? Because I'm trying to reflect on some cases that I handled earlier.
Thromboemboli can originate also in the upper extremities. That is associated with central venous catheters or right cardiac chambers. And it is more important to know that the risk factors are similar in children and adults. And as I mentioned earlier, the risk factors are those conditions that impair venous return, or those that cause endothelial injury, and also those that cause hypercoagulability disorders.
Yes, so I think we need to delve more into the pathophysiology.
Yes, talking about the pathophysiology. You see, once the DVT develops, what actually happens is that the clot may dislodge and travel through the venous system and enter onto the right side of the heart, where it lodges onto the pulmonary artery and may partially or completely occlude in one or more blood vessels.
Dr. Gure, allow me to interrupt you. I believe Dr. Francis wanted to finish something.
Yes, so as I was saying, for a small emboli, there may not be any acute physiological effects because the emboli may rise or just disintegrate quickly, probably within hours or even days. Okay, but larger emboli, they may cause reflex increase in ventilation. You may have shunting, or also you may have increase in pulmonary vascular peripheral resistance, and this would be because of any mechanical obstruction of the vessels and also vasoconstriction. So I think we should go with anticoagulants as the best treatment, so effective treatment for this patient.
Okay. So Dr. Gure, do you have anything else to add to that?
No, it's well said.
Okay. So as we all know, anticoagulant therapy is the mainstay of treatment. Acutely supportive treatment like oxygen and analgesia are often required. But the heparin is administered initially while warfarin therapies commence, and this usually takes a few days while the patient is still in the hospital.
Yes, so with Mrs. John, frequent dose adjustment and monitoring of the INR is essential. Okay, we could give her for her INR, we could give her at least 2.0 to 3.0 of INR. However, if she still has a recurrence of PE during warfarin treatment, then we'll have to increase the INR window to about 2.5 to 3.5. Okay?
Actually, I agree with you, because patients with an underlying malignancy, the line of therapy is usually low molecular weight heparin, and this is preferred to warfarin based on the result of the trial tests.
Yes, but in Mrs. John's case, warfarin therapy should be continued for 3 to 6 months, or even lifelong, due to the fact that she has had previous DVTs, SVT, and presents with multiple risk factors.
No. With Ms. John's case, the best medical treatment is thrombolysis. with the best available treatment, and in this situation is supported by clinical guidelines.
I'm sorry, but the use of thrombolysis in non-massive PEs, it's still debated. The aim of it would be to dissolve the clot. There would be a major risk of massive bleeds, and there could even be a stroke.
On the other hand, pulmonary thrombectomy can be done.
Dr. Hari, you know that is very uncommon and has been largely abandoned, and it suffers with poor long-term consequences on patients.
But recently, it has gone through a resurgence with the surgical technique. So, it has been thought to benefit selected patients. Therefore, it will be the best treatment in Ms. John's case.
Oh, I'm sorry, but with Mrs. John's SVT, it would be almost impossible for her to undergo any operation. Actually, heparin would be a good choice of drug because, it's widely used as an anticoagulant. We have been using this for a number of years. It comes in two forms, the low molecular weight heparin and as well as the traditional form. They're both equally as effective. With Mrs. John's case where she has had previous surgeries and there might be a risk that she may develop new thrombi in the deep veins of the calves, heparin would be a good choice.
Newer anticoagulants include heparin, which inhibit the body's formation of clots, and also danaprate, which inhibit those substances which enhance the body to form clots, and also vandaparinix, which also promotes which also inhibit those substances that enhance the body to form clots.
Okay, so to conclude, based on the angiogram and the ECG and the blood test, Mrs. John had a pulmonary embolism. Since we can't do thrombectomy or thrombolysis, we will start with the warfarin and heparin therapy as Dr. Faisal suggested, but this will only continue simultaneously for a period of 5 days, after which she'll continue on the heparin alone. She'll be advised that compliance with her medication is necessary, and she should also be advised that long flights and cigarette smoking should be avoided.